Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you, Director Margaret. Once again, good morning, good afternoon, good evening, depending on from where you are. We are actually having a very rich week from the new vision of Africa CDC that was published on Monday, with the different engagement that you will see in Djibouti, coming up, the G20, the Pandemic Fund. You will see that we are really pushing the new Africa health, security, and sovereignty. So with that, I thank you once again to all the journalists for being there, for the transparency, the accountability, which is also a great support for all our colleagues that are currently battling all the outbreak that we will be presenting today. Over to you, Director Margaret. Thank you. So as you will see, this Monday, the Lancet has published the Africa Health, Security, and Sovereignty Agenda, the new way forward. If you recall, we have been moving from the time where we were defining the new public health order. And now from this, we are moving to this new era, new way forward, where, as Dr. Jean Kaseya highlight in that paper, this new strategic transition term Africa Health, Security, and Sovereignty reflect the growing recognition that achieving universal health coverage, pandemic preparedness, sustainable development cannot realize without health sovereignty and the ability for African nations to finance, produce, and govern their own health system and countermeasure. And it's aligned or it's rely on 5 pillars. The first one is on the having a more inclusive architecture. The second one is how we improve on the prevention, preparedness, looking at how we respond to public health emergency. We also have the digitalization transformation, the local manufacturing. As you know, Africa CDC has been really pushing to that. And then the third one is really around the domestic, innovative, and blended health financing. Next slide. So those 5 pillars, you will see them as we go along. But before moving forward, just reminder, this week is the week of antimicrobial resistance. And to remind to all ourselves that we all have a role to play. Now, what we are seeing in the continent is that the mortality rate is over 27 deaths for 100,000 people. And this is what we know. The unknown might even be bigger. Now, Africa CDC has really prioritized IMA as an urgent threat, supporting national action plan in most of the different countries, so that we can improve the surveillance in human, but also in animal and plant, looking at the One Health approach. Because as we all know, a significant contribution of antimicrobial resistance comes from the way we grow our animals, in the sense that they are grown with antibiotics and then they transfer to the human being. And as you see, surveillance remain a mega, with only 1.3% of our laboratory having bacteriology capacity. 1.3%. So, which means that we actually don't know when we prescribe antibiotics to our patient. Most of the time, 99% of the time, if you look at this, of the people will take antibiotics without knowing which one will work for them. The political leadership adopt framework and committed to resource allocation, while Africa CDC has established the minimum standard for infection prevention and led regional training and legal framework for IPC. So we really call for more investment, and it goes back, remember, to our pillar, the domestic funding, but also the prevention to public health emergency, because we believe that antimicrobial resistance is the silent pandemic. Next slide. As I mentioned, the week has been reached, going around the dissemination of the new vision of Africa CDC, which started last week actually in UK, where our Director General was engaged with other stakeholders in the global health space at the Chatham House in London, really emphasize that we must build strong system, reliable financing, and African-led action. If you recall the paper that we presented last week, Africa leads and multilateral organization support. So we really want to ensure that this is the new era, this is the way forward. So we really reaffirm Africa CDC together with African Union member states the value of the global partnership. We want that new partnership where we lead and when we have great allies, rather than replace national priorities at the pursuit of a healthier and more resilient Africa. Next slide. This week also was the governing board meeting of the pandemic fund, which happened in Kigali in Rwanda. So first of all, it was an important moment to appreciate the leadership of the government of Rwanda, which has really welcomed all those leaders and re-emphasized their commitment to strengthening pandemic preparedness across the continent. And Africa CDC, through our Director General, underlined that Africa's leadership and needs remain central to the discussion, and that the financing, the pandemic for or order should reflect the continental priorities, which make the link with the Lusaka agenda, pushing us to have our homegrown solution, in this case, to improve the preparedness and the response. Next slide. One of the key outcomes, and we congratulate really all the colleagues that have been working tirelessly on the pandemic fund proposal that was submitted by Africa CDC and partner from WHO. The first thing is that Africa is set to receive 234 million USD, 47% of the total fund approved will go to Africa. So that is critical because it's highlighting that we will have the resources to accomplish the needs plan. We're talking about Mpox, talking about cholera, talking about Marburg, and so on, to prepare our country, but also to have an efficient response to those public health emergency. So we really, as Africa CDC, credit the joint mechanism with WHO for improving the technical quality and funding success rate of proposals submitted by African Union member. As you can see, 47%, it's really an important achievement for the continent. And we also reaffirm the strong commitment to transforming these resources in tangible protection for African community and to champion our new vision, Africa health security and sovereignty. Having the fund is one thing, the efficient implementation of the fund is critical to ensure that at the end of the day, our population are well preserved and that we control as soon as possible all the potential epidemic and outbreak. Next slide. Now, in Djibouti, our Director General attended the Third African Forum for Health Product Supply Chain, and we are going back also to one of our pillars, highlighting the need to invest in strong and resilient supply chain where we save life, because we want no community to be left behind. We want every facility, every health worker to have timely access to essential health product, no matter how remote. So it's really an issue of equity. And we believe that through the regional leadership and collaboration that also include Djibouti's role on logistic hub, we can really build that healthier, safer, and better prepared continent of Africa. Next slide. The initiative that the Nigeria is leading, which we call the SWAP reform, is a critical one, where we want countries to have only one plan, where all the activities are together, well planned, well prepared, well costed. And this sector-wide approach, which is called SWAP, is really strengthening the coordination. It improves the governance, accelerating the impact, and also reflect the impressive leadership and commitment. That will increase transparency. That will also increase efficiency. So our Director General really, to the invitation of Professor Mohamed Ali Pate, went to really support this initiative to the extent that in 2026, Africa CDC will convene other member states to learn from Nigeria's experience and collectively bring a stronger, more resilient health system across our continent. Next slide. Now, coming down to our public health event, as you can see, they keep on increasing. Now we have a 58 very high risk event, 128 moderate risk, and then we still have Mpox, which is leading in the number of member states that are affected. Currently 27, but since the beginning we had the 30. And cholera, you can see that we moved from 23 countries affected to 24. I will come back to Cameroon that has detected 2 new cases of cholera. Have measles, dengue, Lassa fever that are still an issue in our continent. Next slide. Now, currently we are in Ethiopia, in Addis Ababa, where the Federal Ministry of Health and the Ethiopian Public Health Institute have informed the South Ethiopia, in the Jinka town, the Marburg outbreak. So far, has been declared 28 suspected cases, 4 cases has been confirmed, and 3 deaths have been confirmed among the 4 confirmed cases. So as you can see on the map, the Jinka town, which is in the south region of Ethiopia, is bordering to Kenya and also South Sudan. So the symptoms that you receive with Marburg include sudden fever, severe fatigue, muscle pain, headache, vomiting, diarrhea, and in later stage, unexplained bleeding, which will lead to death. As you can see, out of 4 confirmed cases, 3 has passed away, which made a case fatality ratio of 75%. Now, we commend really the leadership of Ethiopian government. We have deployed multidisciplinary rapid response team, activated the incident management system, and also as we do speak now, there is a meeting with all the different partners to technically see how we are going to support, how we are going to accelerate and control these outbreaks. Next slide. So in a spirit of transparency, solidarity as well, we, with the Director General, has made the Minister of Health on Sunday to really commend the leadership of Ethiopia Minister of Health, because we know that one of the 5 key drivers for successful response is the leadership at the level of the Ministry of Health. So we congratulate that strong and timely management of the Marburg outbreak, and also we discussed the next step. As mentioned, currently there is a technical meeting happening at the APHI with the different partners, one to have the information, but also to agree on where are the gaps and how different partners, including Africa CDC, can support. So we really stress that Africa CDC will continue to stand with Ethiopia during the critical period. And we believe that all these outbreaks are opportunity to strengthen, to build the health system. Next slide. As mentioned before, Jinka is bordering Kenya and South Sudan. Therefore, we have also engaged the Minister of Health of South Sudan so that we can support the preparedness just in case there is any case that can move to South Sudan. But we really appreciate the leadership as well. They've already activated their EOC. We also have some readiness assessment that has been happening, and we can confirm at this point that South Sudan has the needed laboratory reagents, so that in case there are some suspected cases, they will be able to detect. They will be also able to do the sequencing. There are some needs that we are going to support. Next slide. Now, going to DRC, we are still in the countdown for Ebola virus disease, and then we really commend once again the leadership of the country. This is also an evidence of the maturity of the National Public Health Institute, which is a cornerstone on the response to outbreak in the continent. So now we are left with 11 days before the declaration of the end of the outbreak. 48,000 people have been vaccinated so far. So we are quite confident. At the same time, we maintain the surveillance to ensure that we go up to the end, the declaration, without any new case appearing. Next slide. Fever in Senegal is decreasing. As you can see, the number of confirmed cases are moving from 40 to 32 in this week. We have been seeing one death. The total patients that have recovered is 416, while we have one patient that is currently hospitalized. So this is also important to see the progress that has been made by the Ministry of Health of Senegal, and ensuring that they push the control of the disease. However, there are cases that are spreading to the southern part of the country with potential new cross-border transmission in Gambia, Mali, Guinea, and Guinea-Bissau. That's why our partners from the MSD, specifically on the WHO, were also moving toward those countries to see what is their level of preparedness, so that they can also have all what is needed in terms of detection, surveillance, in case they also see some suspected case of Rift Valley fever. Next slide. Coming down to Mpox, we follow with the decline in the number of cases, as you can see, with the suspected case going down from 1,586 to 1,331, and as well also the new confirmed case. We are also appreciating Sierra Leone. Last week, we had the opportunity to have the Ministry of Health of Sierra Leone highlighting how the country is managing to go to the 0 case for the last 90 days. I think that's really important to see, to learn from those countries, so that the lesson learned from Sierra Leone will actually, as you will see later on, support the neighboring country, which is Liberia, which is one of the countries of concern. Next slide. Now, talking about the countries of concern, you can see the number of cases in Liberia continue to increase, with 20% of increase since for the last 6 weeks as compared to the other 6 weeks. Central African Republic also, we see an increase, though the number are quite low, but you can see that the number of deaths are important. 4 deaths, while in Liberia they have 6 deaths for almost 20 more cases than we can see in CAR. So it's quite concerning, and then we are engaging the country to better understand, and also to support on the vaccination, which has been started at some point. Ghana and Kenya, we can see some reduction, but we can still see that the number remain quite important. Next slide. Sierra Leone, as mentioned, we have 23 days actually since the last report has been confirmed. And as we move, next slide, as we move to Liberia, we will take some of our experts from Sierra Leone, as we did for the interaction review, go to Liberia and see how they can support the surveillance, the active surveillance, and build on the lesson learned. As you can see, what we have in Liberia, we have what we call the test positivity rate. I believe that now all of you are expert in our epidemiology, and we can see that 70% of the positive cases are the one that we see at the health facility, which means that we still don't know what is happening in the community. And that's why it would be critical to have that active surveillance in Montserrado, and also Nimbia, that are accounted for more than 70% of the case. So this is the approach that has been used in Sierra Leone, in Burundi, in DS, and in most of those countries, as well as the isolation of the positive case. So that's where we are going to support Liberia. We have a team going next week to support on the laboratory and some of those aspects together with the partners of the MSD. Next slide. In Kenya as well, we see some increased number of cases from 9 to 44. This might also sometimes be the backlog in terms of testing, but still, we can see that Mombasa, Busia, and Nairobi together still account for 67% of the total confirmed case. The positivity rate is pretty high, 51%, while we expect it to be like the week before at 35%. We are showing that the active search is going on. But at the same time, as we'll see later, Kenya is also battling another outbreak of cholera. Next slide. In Ghana, the situation is improving for the last 3 weeks, which is also quite reassuring, but especially knowing that 72% of the confirmed cases are actually concentrated in the greater Accra and the western part. So this is really the place where the vaccination, the surveillance, the RCC, and all those activities should really be accelerated. And we are glad to see that the test positivity rate of 25% emphasize an active tracing that is happening. So now the next move is really to push with the new allocation of vaccine and the integrated surveillance so that we can really touch in those hotspots, those who we need to protect. Next slide. In terms of vaccination for Mpox, we are still moving toward 5 million doses that are delivered in the 16 countries. We have the approval that has been granted on the 18. So what is important to highlight here is that we have almost 80% of the countries with Mpox vaccine that have used more than 50% of their stocks. This is important because it's also highlighting the willingness and all the effort that the country are implementing to ensure that the vaccine are being used to protect their population. And this is despite the challenge that they are facing in terms of the availability of operational fund. We have Uganda that has received 100,000 doses of vaccine a few weeks ago, and which will rely on domestic funding to actually deploy those vaccines. So that's something to emphasize and to commend. I mentioned that Liberia is one of the most concerned countries as we do speak now, and then gladly, next week they will be receiving 20,000 doses of vaccine, and also Kenya will be receiving on the 10th December, respectively. Next slide. Cholera in Africa. This is our major battle as we do speak now, because mentioned again, 3 times more case and 3 times more death as compared to what we see 3 years ago. We were at 23 countries last week. Now we have 1 new country that is reporting cholera. And again, as we mentioned, we are going toward the rainy season in some of those countries. So we have South Sudan, DRC, Angola, and Nigeria that contribute to almost 90% of all the cholera cases. So those are the top priority countries where most of our action will be supported. Currently, our team at IMST, which include, as you know, WHO, Africa, CDC, but also all the expertise that has been developed on cholera. We have the Global Task Force, we have the Wellcome Trust, we have all those partners that have been involved in cholera, joining us hand in hand so that we can really push specifically on those hotspot countries, and then we try to bend the curve using some innovative way of responding to cholera. Next slide. So now looking specifically at the trend in those countries, Angola, as you will see, we keep on seeing that increase, and we are engaging the country to see how we can support and accelerate the support in different ways on the vaccination, the surveillance, but more importantly on the WASH. Burundi also, we can see the increase, though it's a bit low. And we have DRC. Gladly, we can see a decrease, but still, we had in the last 5 to 6 weeks, 7,000 cases. This is the highest number that we've seen across all those countries. And in Angola, as you will see later, we have this resurgence of this new wave that is coming, while we were quite happy to see that the cases were reducing. Next slide. As I was mentioning, Angola. This is a country with a case fatality ratio of 2.6%, and you can see the second wave gladly is going down. So we are monitoring, we are supporting, but we are gladly to say that from last week to this week, we have moved from 606 to 500 cases, and the number of deaths also has reduced. So the hotspots remain the same: Kwanza Sul, Malenge, Yola, Kunene, and Namibe province. The key challenge that we see there is really the wide geographic spread. 152 municipalities are affected, which really complicate the logistics. And that's re-emphasized the challenge of the need of the multi-sectorial approach, because at some point reaching those places needs some external resource and support including the logistic. Roughly 44% of Angola's population lack access to safe drinking water, and only about 55% have adequate sanitation. So when you look at it in that perspective, you can understand that if nothing is done on the side, out of the health sector, on the side of infrastructure, well implement those sanitation, because having the sanitation does not mean that they have access to safe drinking water. So that's something critical to push, to scale up the WASH infrastructure, which means investment, not at the medical level, but really at the political level. Next slide. In Burundi, we are seeing some decrease as compared to the other week, though if we compare the three last week, we can see that decrease. Now, the case fatality rate remain pretty small, 0.4%, and we believe that is one of the strengths of Burundi. Whether we are talking about Mpox or now cholera, we can see a very low case fatality rate, while in some countries we are 2.6, even 7%. However, the challenge remained the fragile water infrastructure, and the onset of rainy season pose ongoing risk of spread. As I mentioned, we are in November, going toward December, the rain will be increasing. So it's urgent to really ensure that the access to clean water is improved. Next slide. Kenya, I mentioned that Kenya is now battling Mpox on one side, cholera in the other side. Gladly, we can see a small decrease in the number of cases. We have one that has been declared last week, and you can see the case fatality ratio is around 4%, which is quite high. Just to remember, 1% is a threshold that is not acceptable, but reasonable in those in the response to outbreaks. So the hotspots here are Narok, Migori, and Narok. And the intervention that are implemented is really training the clinician on cholera management, but more critical, the distribution of water supply. And this is the wash and medical solution. But in the long run, what is urgent is really to increase the access to water and sanitation. Next slide. I mentioned that we were 23 countries with cholera last week. Now we have Cameroon that has declared 2 cases notified from Nigeria on the 5th of November 2025. This is in the region of Mayo Ulo district, which is in the far north of the country, which is neighboring Nigeria. So the main challenge here is really the accessible due to the rocky and mountainous environment. So the incident management system has been activated, the deployment of rapid response team also. So we can say so far that the country is really controlling these outbreaks so far, and we believe and we hope that there will be no more case. Next slide. So in summary, we are in the countdown for Ebola. We had 31 days since the last confirmed case was discharged. For the Marburg virus disease, we are in Ethiopia supporting the country that have declared those 4 cases and 3 deaths. So the leadership is critical and emphasizing the surveillance that is happening within the community. So we expect to have some good outcome from this response. On Mpox, we can continue to see the decline, though we have these countries. We have Liberia, we have Guinea, Kenya, and Ghana, where the number of cases still remain important and where we need to focus, accelerate on the support. On the cholera side, we have one new country, which is Cameroon, that has declared two cases. And we have the mixed trend where we have Angola, Kenya, and Burundi that has some increase, while we have the other countries that see some decrease. However, DRC, despite the decrease, still reports 7,000 cases in the last 6 weeks, which remain quite important. So with that, I will be happy now to take some of your questions from the journalists. Over to you, Dr. Margaret.
Thank you very much, Prof. Let's take the first 2 questions. We have Walter Mwesiga from National TV in Uganda. The question is, where are we regarding technology transfer to enable things like test kits to be manufactured within Africa? That's the first question. And then we have the second one from Sheriff Saidikan, is the Vice President of the Gambia Press Union. The question is, As Marburg surges to 28 cases, the contribution of member states is vitally important in the fight against public health emergencies. Can member states map out strategies and accelerate efforts to support public health emergencies facing the continent? Back to you, Prof.
Thank you so much. That's two very insightful questions. The first one is on the tech transfer, which, if you remember, on the 5 pillars that in the new vision, we have that new vision of Africa, health, security, and sovereignty, where the local manufacturing really hold a very critical component. So specifically on the diagnostic, this week we held as the Diagnostic Advisory Committee, the DAC, which is supporting the local manufacturing to find the best way to ensure that they are in the position to produce locally the kit with the support of Africa CDC. So this meeting happened this week. We are yet to get the outcome and see how we move forward to ensuring that what we've seen during Mpox, having Morocco producing PCR against Mpox, so that we can see that more and more. The second question from the colleague from Gambia, the contribution of member states to MVD, Marburg virus disease. I think we commend the leadership of Ethiopia. So far, they have been the one really leading the response, ensuring that they have this active surveillance. They were starting the door-to-door surveillance to ensure that, one, the right information is communicated in the household, and two, if there is any suspected case, they can provide the adequate support in terms of testing, but also in terms of infection prevention and control. And this is being done by the leadership of the Ministry of Health, by the government. So this is a good example of a member state that is implementing the response. On the other side, the colleagues are currently at the Ethiopian Public Health Institute to also get the feedback on where gaps are being identified and how each partner can come and support. So this is really a good example on how we want our country to show maturity on the way they respond to those public health events.
Thank you, Prof. Let's cross over to the floor. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you for this opportunity. So I was going through the document, the AHSS document, and one of the first things that came to my mind was we had the National Public Health Order just 3 years ago, backed by the African Union as a political declaration, and now we are having a new document again. Will this go through the African Union too as a political declaration, or this is something that is going to stand alone for the Africa CDC? And one of the issues I'm seeing in a big question I have regarding the AHSS is how is it going to be funded? Because I see the financing vision as very ambitious, but the mechanism for securing sustainable continent-wide funding remains vague. And one issue that is also happening this week, which is the Antimicrobial Awareness Week, also highlights another gray area that I could see in the document, which is question about political will across 55 member states. We saw that happening with the Africa Drug Regulatory Agency that was supposed to bring African governments together, and how a lot of African governments were reluctant to actually sign up to this. So while the agenda assumes unified continental action, but Africa has significant policy heterogeneity. So how are we going to deal with that? So I have a last question, which is on the reliance on external tech firms while we are still trying to claim data sovereignty. I know that the document highlighted an MOU that was signed with Starlink. So if we are talking about Africa being sovereign, achieving data sovereignty, why are we still embedding external tech firms into our policy? Thank you very much.
Thank you, Paul. Back to you, Prof. There's quite a number of questions.
Thank you so much, Paul. I think with you, we can do the entire briefing with all those very insightful questions. We have Dr. Mirawi, who is connected, who will respond to the question on antimicrobial resistance. Now, you start by highlighting that the shift from the new public health orders to the Africa health security and sovereignty. And this is not coming from Africa CDC on its own. You rightly mentioned that the new public health order was coming from the 2022 engagement with the head of state. This one also, and I'm sure that if you read it well, you will see that it's also coming from the engagement of what the presidential 2025 meeting, the committee of head of state and government that went together and also emphasized that considering the evolution, we've seen the decrease on ODA. We've seen the impact that it has been having on our people. It's important to highlight that. And based on that, they say, okay, how can we then be more efficient? How can we take the sovereignty in the financing? That is the first question that you were asking. How are we going to fund? The first thing is, why are we not funding well what we need to fund? And one thing that has been highlighted is all the inefficiency that we see on our health system. Dr. Kaseya was talking about the ghost servants, and there are countries where we have some data where around 40 to 50% of the servants in the Minister of Health are ghosts, so people who don't exist. And then some country, I think is DRC, will lose actually $800 million per year because of that. So just imagine if we manage to solve those inefficiencies through the digitalization, as we've seen in Rwanda, then we'll avoid having those kind of inefficiency. And if you keep on reading in the document, you will see those initiatives like pool procurement. If we have those mechanisms that are functioning as we support countries like Namibia and also Botswana when they were having the crisis, those pool procurement will save between 30 and 40% of the cost of the procurement of some of the medical countermeasure. So going into that, you will see some critical aspect where simply doing the right thing in the most efficient way will already produce a significant amount of resources before even moving in other way to gather more funds. So you mentioned how can we then talk about sovereignty while at the same time we have this partnership with Starlink and so on. I think it's also coming to the question on the tech transfer, and I bring you back to the other article of Africa Lead and Multilateral Support, where we are not saying that we'll do everything on our own, because today we don't have that capacity. We don't have the capacity to provide this good internet, and we know that without the right connectivity, all how the response is really critical. If we see the way the response has been happening in DRC on Ebola, one of the key drivers of the success was to have an active surveillance. The data can move pretty fast, and this is because we had the opportunity to support the country with Starlink, and then the colleagues on the ground could have data, send them, and then the response could follow. So it's a partnership. It's a partnership. We are living into an interconnected, interdependent world. So there is no way we'll do everything on our own, but what we are saying in this new vision is that we lead. We know exactly what are our priorities, and the partner will come and support. So now I can leave Dr. Mirawi answering the question on the antimicrobial resistance.
Thank you very much, Prof. Yeah, thank you very much, Prof. Yes, apologies for the hiccup. Paul, thank you very much for that insightful question. Regarding antimicrobial resistance, indeed, it is becoming a global pandemic with a high burden, which is comparable with malaria, TB, HIV diseases per year. Yes, there are so many political declaration at a high level with UNJ declaration last year in 2024 and also in 2016 and so on. The countries have been working with in silo to develop national action plans on AMR. But indeed, those things were not really funded as not like One Health approach. If you see antimicrobial use is not only the health sector, the animal sector, the food, agri-food industries use over 70% of antimicrobials for their production and animal health and so on. So we, as African Union, Africa CDC, have been putting a task force at the African Union level, led by Africa CDC and AU IBAR as One Health. And we coordinated the African common position, and we support multi-sectoral coordination mechanisms and development of national action plans and funding of those national action plans. Recently, over 47 countries that developed a national action plan on AMR, but still on the funding and the local capacity and diagnostic capacity and surveillance capacity are limited. We are working towards that to engage as a multi-sectoral approach, funded plans, national action plans, and so on. So we want really all the media here to take, and I take this opportunity to really advocate for antimicrobial use, proper use of antimicrobial, and prevention of antimicrobial resistance. And here we also are advocating this week in our compound and also globally. So yeah, that is what we really need. Everyone's, all stakeholders to be engaged in and giving due attention to the defense mechanisms that we have against infectious diseases and beyond, so that we can have really a better future. I mean, antimicrobials is really becoming really major burden unless we acted today. So just that is in a nutshell. And yes, there are difficulties, challenges, limitations in capacity, but there are some policy commitments that we see in countries like Ethiopia with One Health kind of approach that they launched today, even in our compound, the National Action Plan on AMR. This is very commendable thing that we are really advocating for. Thank you very much. Back to you, Margaret.
Thank you, Merawi. Let's move on. We have Sarah Javing from DVEX. Sarah, you have the floor.
Thank you very much for your presentation and taking my question. There are teams from the U.S. State Department moving around the continent for negotiations for bilateral agreements at the moment. What is Africa CDC learning about what's being discussed at during these negotiations? Dr. Kaseya had mentioned last week that he was going to touch base with Nigeria about their conversations. And then additionally, what messages does Africa CDC have for African negotiators as they move forward with these conversations? And I'm wondering if you might be able to share the list of the 16 countries that are currently amid negotiations. Thank you.
Thank you, Sarah. Let's take the next one before Prof comes in. We have Rachel Abuja from Nigerian News Agency. Rachel, you have the floor.
Thank you very much, Margaret, and thank you, Dr. Yeah. My first question is going to be with the cholera case now 3 times higher than where we were 3 years ago. What concrete step are we looking at, Professor Yab, so that we can mitigate the top burden countries like my country to see? And with African CDC emphasizing cost saving through efficient procurement and the role of technology transfer in outbreak response, how can this mechanism be scaled across the continent to strengthen both AMR surveillance and rapid epidemic response? My last question is, given that only 1.3% of laboratories in Africa have the bacteriology capacity, how soon can the continent realistically expect improvement in antimicrobial surveillance and antibiotic and stewardship? Thank you, and over.
Back to you, Prof.
Thank you, Rachel and Sarah, for the question. For the question on antimicrobial resistance and the laboratory, I will let Dr. Mirawi to comment on that. On the one from Sarah on the U.S. bilateral visit in the countries. So will find the list and then we'll communicate to you the exact list of those 16 countries. And as you mentioned rightly, Nigeria was one of them. What's happened is before the visit, Dr. Kaseya engaged all the 16 countries to first agree that it's a good opportunities to have that conversation between the US government, highlighting the new vision and engaging the different countries. So that's the first important point that has been mentioned already. Now, as we move toward those bilateral engagement, what is planned, and he also mentioned that last week and also when we were at Chatham House, that there will be another meeting to touch base with all those countries and understand what is the perspective, what is the feeling, and how, as the continent, we can move together as we want to move with unity and ensuring that all the continent get the best on those upcoming partnerships. So the question from Rachel on the cholera, saying that yes, we are seeing the number of cases and deaths that has tripled. What are we doing differently? The first thing that we have been doing differently is to follow the instruction of our head of state and government. They say instead of responding the way we've been responding, that each organization will do its own, let us bring cholera within the incident management support team that has been used to respond to Mpox. So having that coordinated approach where we see all those partners, WHO has been doing quite a significant amount of work on cholera. The Global Task Force also, there is that Agenda 2013 for the elimination. We have researchers that have been working on their side, finding some very important evidence on how the vaccine works or how it does not work, how the wash is working. And actually tomorrow during our IMST meeting, we have some researchers that will come to present to us the latest evidence. And it's that platform where we will intervene, we will discuss, where we'll find what are those innovation that we need to implement. But we know already that we need to have that multi-sectoral approach. As I was showing in one of the countries where 50%, I think it's Angola, where 40% of the population don't have access to safe drinking water and sanitation. This is not the Ministry of Health. So one thing new that we are also doing is to engaging the champion, the president of Zambia, who will now push or support the facilitation of presidential task force. This is something new, where the president in those countries will ensure that all the different ministries, finance, infrastructure, water, and so on, will support the Ministry of Health on ensuring that the access to sanitation and to clean water, because having sanitation is one thing, having the clean water is something else. So this coordination is what is new, but we need a bit of time to see how the evidence and how the work will produce some result. But we are confident that bringing good brain together with the same will be able to have an impact on cholera in your country and in other countries. Dr. Mirawi, for the question on IMA and the low number of laboratory able to do the antibiogram. Over to you.
Yes, thank you. Prof. Yap. Thank you, Richard, for that question. It's indeed very, very important question. Unless we address this, surveillance of antimicrobial will be really blurred, and we'll be navigating without really good data and evidence. So we have done, with all partners collectively, have done this assessment across 14 AU member states, and we found there is a very limited laboratory capacity across those 14 member states, and only 1.3% of labs are able to do such kind of test. This is really very, very worrisome. So what we have done now in our strategic plan that we developed, and our landmark report, which has been launched in UNGA last year, if you remember, is we clearly set all the clear objectives and activities that we can be done to enhance surveillance and the prevention and control of AMR across all different pillars. So one of those things that we are putting as a flagship is enhancing laboratory and surveillance capacity. And we are currently working with all partners, including African Society of Laboratory Medicine, Team Europe Initiative, which is the collective of the EU member states, and as well as the World Bank to enhance surveillance capacity on AMR across the continent. This is a comprehensive package that we have, including capacity building, laboratory enhancement, and we envision by this the strategic period that we put, we will achieve significant amount of improvement in laboratory capacities, and improvement in AMR surveillance and stewardship in general, and understanding and awareness of the community, the healthcare workers, animal health workers, food industry regarding AMR and AMR initiatives. I think that is what we put. We'll be very happy to share the landmark report here in the pool in the chat box, so that you can also refer and assist us in the key message delivery, particularly in this week of Antimicrobial Awareness Week, the global, World Antimicrobial Awareness Week. Thank you really very much.
Yes, thank you so much, Dr. Mirawi. Maybe to also add that we have here an opportunity of integration. You do remember the effort that has been implemented in DRC, in Burundi, where the lab decentralization has been one of the flagship of the response. And those platforms, those molecular platforms, can also be used for the antimicrobial resistance. So I think that's an opportunity that where we are supporting countries. I think the lab decentralization policy or strategy for Burundi, for example, is also looking at how these equipment can be used beyond the Mpox and other, but also integrate the testing for antimicrobial resistance. Over to you, Dr. Margaret.
Thank you, Prof. Let's take the last two questions. Actually, we have one here that says, with regard to the Marburg outbreak in Ethiopia, what lessons are you applying from the outbreak in Rwanda? That's the first one. And then the last one here is, could you brief us on the findings of the Africa CDC mission to Sudan undertaken on the wake of the attack on the major hospital in Darfur? Back to you, Prof.
So the first one on the MVD in Ethiopia, one of the key lessons learned from Rwanda was the speed of including the use of research for the therapeutics, the remdesivir, but also the vaccination. If you recall, in Rwanda, they vaccinated 1,800 people around the case using a research protocol. Maybe Dr. Musoka will add some few words on that. So now what we are doing as Africa CDC is to facilitate that conversation between the two countries, so that not only the lesson learned, but also the tool that has been used will be mentioned. Maybe Dr. Musoka, if you can highlight on that. Dr. Musoka or Dr. Mirawi, who are also involved in the response
Hello?
in Rwanda? Yes, we can hear you, Musoka.
Hmm? Hello, yes. So
we can hear
basically,
you.
we use some of the, can you hear me? We use some of the experiences from the Marburg Rwanda case to already support, avail ourselves to support some of the ongoing work in Ethiopia. As you will know, that Rwanda, in a lot of ways, use multiple research approaches to manage the Marburg. In addition to optimal center of care, we saw the deployment of remdesivir, deployment of the Child 3 vaccines. And so all we saw is an example of a rapid containment. And as a result, we are working with them a couple of projects like the multi-country reservoir of Marburg in 6 of the East African countries that we're currently developing. So it has always been a model that we've used to support research response for continuing outbreak, and they've been very responsive to support other countries. Thank you.
Okay, thank you very much, Mosoka, on that. On the other question on the South Sudan and the feedback from the mission that we had with the colleagues on African Union, Peace and Security. This has also catalyzed some conversation that were implemented, but try to accelerate with other humanitarian partners, including MSF. There's been some meeting and engagement, and just before this meeting, we have other partners like APORA. APORA is a network of humanitarian military association that has been working in many places, and now we are trying to find how we can work together because they have a better understanding and a better way of responding in those kind of environments. So that this is really where we stand, because now the country, on top of the insecurity, on top of all what you've mentioned, we have cholera, we have now talking about South Sudan, we have now the preparedness and the risk when we talk about MVD. So this is a catalyzer. We consider outbreaks as opportunity to strengthen the response, and in this case, it's really to bring those partners, those APORA, those MSF, a bit more in that coordination so that we can really solve the issue. But again, those issues are not solved only at the operational level. They are solved also at the political level. And that's where the voice of Africa CDC, supporting with the support of AU, will do our work to also see how we can push for a peaceful environment where we can at least have some time for the humanitarian actor to have access to the population. Over.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you for your closing remarks.
Thank you, Director Margaret, and thank you really to all the journalists. You were quite a number again today to come to gather the right evidence, and then I believe that we were talking about antimicrobial resistant weeks. I believe that some of you will communicate on that so that we can sensitize our population, our community at a different level, at the level of the community, at the level of the agriculture, but also at the strategic and political level. That is critical. We've also, through your question, engage on our accountability and ensure that what we do is what we say is what we do. And last but not the least, we also count on you on sharing, disseminating our new vision to ensure that it is well understood, well appreciated. And I believe that, Paul, with the question you were asked, you got your answer. And with that better understanding, you will be one of our ambassadors. So with that, I wish you all a very nice day, a very nice afternoon, and a very nice evening. And happy to be with you or the Director General next week at the same time. Thank you.